And now I'll introduce Todd Maxon, our last speaker for this first half of this session. Todd is a professor of surgery at the Arkansas Children's Hospital and chief of the trauma program there. He's also the state of Arkansas consultant to the state of Arkansas in the Department of Trauma, and has been active in a leadership role in the American College of Surgeons and Committee on Trauma. And Todd is going to talk to us today about trauma systems. So Todd, if you're ready.
I am, Rich. Thanks so much. All right. Well, again, thanks, Todd and Rich. Thanks so much for along with the Childress Institute and Cincinnati Children's, for allowing me to spend some time with you today, and your interest in this topic of pediatric trauma systems and sort of where they really fit in. I think the concept of injury dates back to antiquity, and so the care of injured patients is not new, but a place where you go to be cared for specifically for that disease. Trauma is a relatively new concept. You can find places back in the 40s and 30s and even 50s where they began to focus on these issues. But here in the States, really, it probably was Dr. Cowley in Baltimore, and maybe some movement in San Francisco and Chicago that led to our initial experience in the United States in development of trauma centers. And from the concentric rings went out to really develop trauma systems. In the state of California, down in Southern California with Dr. West, and in the Bay Area with Dr. Trunke, any two trauma centers in close proximity are, as surgeons are wont to do, are going to compare their outcomes. And the groups in Orange County and San Francisco did just that in the late 70s and found that there were specific elements in the care systems in those places that led to optimal outcomes. And from that, the beauty of this was that spurred on a discussion at the national level about optimal resources for the care of injured patients, and that informal gathering of trauma surgeons and trauma folks around those initial studies really was adopted then by the American College of Surgeons ultimately, and became what you know today as the resource guide for optimal care of injured patients. And this obviously is the criterion book that the Committee on Trauma from the American College of Surgeons uses to verify trauma centers. And you notice we're missing the recent edition of the Orange book in that group. But we've been through 5 different iterations of that. So maybe to our experience in Arkansas, it's illustrative of this issue. I was recruited back to the state of Arkansas in 2009 to help with both the hospital system and the state's trauma system. And I knew in coming from national data, CDC data, that the state of Arkansas had a real public health crisis. If you were a child injured in a motor vehicle crash in 2007 or this 1999-2007 range, your chances of dying from that motor vehicle crash were about 3 times the national average. The mortality was absolutely the highest in the country. And yet when I interviewed at the Children's Hospital, they said, we don't really have a problem here. Our mortality rate is 1.5%, which was very much in line, if not lower, than a national average. And so we began to dig into that. And what you realized was that in this state of almost 3 million people, where it takes about 4 hours to drive from the center of state to each of the corners of the state, only 12% of critically injured children made it to the Children's Hospital. 88% of children that died in our state died either in the field or died in the first hospital or died in transport between the first hospital and the tertiary care center. So I think the challenge really to us was to look not only inward toward our operations at the hospital, but to think of ourselves in a more global sense, to think of ourselves and our role really in the system. So if we were interested in really what was the best care for injured children in the state of Arkansas, we had to look outside the walls of Arkansas Children's Hospital and outside the city of Little Rock. Well, the system was coming into its own in the late 2000s and early 2010, and we spent a lot of time working on infrastructure for the system, and at every step I thought it was important to be sure that as we talked about pre-hospital and hospital designation and rehabilitative services, to keep in front of the decision makers the care of the injured kid, and to point out that sure, while the ABCs of trauma were the same, and some of the issues that we were talking about transcended all age groups, if we didn't pay attention to the anatomy, physiology, psychosocial needs along the age spectrum, that we were going to actually make big mistakes on each side of that issue. So I think for my talk, you've got to believe a couple of imperatives. Beth alluded to this a moment ago in her question and answer, and I can't agree more. There's something about striving for a verification that improves the outcome of care in an organization. The literature's borne this out on multiple occasions. Those hospitals that achieve state and provincial designation do better than non-verified. Those that achieve an ACS verification do better than state and provincial verified centers. Those that strive for a higher level do better. PEDS centers that come on board and dedicate themselves to that very important injury mechanism do better. All those are truths. I think what one of our next few presenters, David Notrika, showed us in a brilliant paper in 2011 was, however, that there was something more to this, that yes, the care at the hospital definitely got better, but the care in the whole community was improved by the presence of just one single pediatric trauma center. So there's something to that. There's something about the hospital striving that transcends the walls of the organization, move out into the community to improve the health. And I think those of us that are public health trained understand the Haddon matrix and know that treatment is one very small part of the continuum of care, and that really the pediatric hospital and the pediatric providers must be pervasive in every one of these areas if we're going to make a global impact in our community. So I'll start with our system and what we found very important. In the pre-hospital area, it's very clear here, even in the United States. Ben talked about it internationally, but in the United States, it's very rare that a paramedic in the United States sees a critically injured child. The further out you go from an urban center, the more important that is, and the more likely that is that, sorry about the paper, the more likely that it is that they don't see an injured child for quite some time, and that education and opportunity to get inside the children's hospital and to co-locate with pediatric trauma experts, be it those in the emergency room, surgeons, anesthesiologists, nurses, is critical to the ongoing skill development in the pre-hospital arena. This is the way pediatric patients look to most people, unlike us, who see this every day and become completely comfortable. It's a terrifying experience. And I think that we underestimate at times our position, the bully pulpit from which we can go out and affect change in the pre-hospital area. The next is in our first hospitals. As I said, 88% of the children that died in the state of Arkansas prior to 2009 died in the pre-hospital arena or in the first hospital. So there were opportunities for us to put the pediatric need in front of these pre-hospital providers at every step, to mandate education, to mandate equipment on their trucks, to go out and verify that, to teach the use and the appropriate use of that equipment in those areas. The same thing was true in our pre-hospital areas. We did an interesting preventable mortality study that we're finishing up the post evaluation now and getting ready to write up for the Journal of Trauma. But what it showed is that children weren't dying in Arkansas from things that weren't done in the tertiary care hospital. It was very rarely something that my partners could have done highly technical in the children's hospital. It was errors of omission in the first receiving hospitals or in the field. It was lack of putting in the ET tube when the ET tube was necessary. It was lack of putting in a chest tube when a chest tube was necessary, or inappropriate fluid administration, or delay in care that was unnecessary that led to preventable mortality. So getting out in those community hospitals and working with them as Beth said, on appropriate equipment, their readiness, their training, integrating, as Rich said, with imaging and easy access to the tertiary care center was really critical in the improvements that we saw in our state. We were also able to work with our leaders at the lead agency of the Department of Health to bring some of those incentives in as a pay for performance. So if you had clinical practice management guidelines that incorporated the pediatric patient, if you standardized some of that care, much as Beth was talking about, we incentivized that from the Department of Health, from our trauma system funds, and saw tremendous improvement throughout the state. As Rich alluded to a little bit ago, we thought it was important to move our expertise as far forward in the system as possible. Again, in our state, it takes 3 hours to get to each corner by ground, and oftentimes air ambulance service isn't available because of weather. And so the use of telemedicine is critical for us, and essentially we use it almost on a daily basis. That I was able to help a young family medicine physician put a chest tube in a child before leaving on a 2-hour ground transport night before last. And so again, not highly technical stuff, but the technology that's being pioneered and sort of the lessons that we're learning from Rich and Cincinnati Children's have been applicable in our system as well, and I think are clearly applicable on a much broader scale. So in the specialty transfer of these patients, sure, we'd like to send our transport team from the center of the state out to the corners of the state to bring patients back, but there are times when time-sensitive disease doesn't allow that. The non-compressible hemorrhage in the chest or abdomen, the extraaxial hematoma in the head, all of those things really need the most expeditious route of transfer. And so translating these skills to the mostly adult-based transfer services that are out there, trying to get them up to speed with what our internal service could do has been a challenge for us. And we've integrated, again, telemedicine presence in that process as well. So I think there are a lot of opportunities for pediatric emergency medicine, pediatric trauma providers. I think they have to take a lead role. I think you have to think about yourself outside of your institution and work, first of all, with the parties that are responsible for determining the priorities of funding, education, and outreach in the community. And that's usually the lead agency here in Arkansas. That's the Department of Health. And so our integration with the Department of Health has been paramount in the changes that we've seen. We've worked with the medical consultants and medical control people from the different pre-hospital areas, as well as we've put together educational packets that we've been able to blanket the state with so that nobody in the state has not had opportunity, and most have been mandated to participate in some pediatric specific education that, to Beth's point, really improves the readiness in our state. I think I also serve as the vice chair of the College of Surgeons Verification Committee, and I struggle with this a little bit. I think that the college at times is adult centric. I think that process can be adult centric, and I think it's important. And I appreciate my colleagues in the pediatric field who help the ACS and the COT specifically remember that there are differences in the ways that we care for pediatric patients. We're a much more collaborative group with intensivists and emergency medicine groups. Our outcome metrics are different, and our benchmarking and some of the risk adjustment methodology needs to be different, and we must integrate in every aspect of our care the psychosocial differences and the psychological impact, which ends up becoming a tremendous long-term burden and morbidity, sometimes much greater than the injury itself. We've got to take stock of those things as we write policy at the national level. I think that we're called on to participate in programs like Beth's program and even some local collaborative groups, like a group that David Notreek and I participate in, and Cincinnati participates in other collaborative groups. But I think, the volumes are small, and unless we organize around a lot of different centers, we're not able to answer questions in a timely manner. So I think that's one of our challenges, and I appreciate PCARN and HRSA for sponsoring a lot of that care. Rehabilitative care is a big issue in our state, as they are in many places, and that if you're lucky enough to be in a children's hospital that has a dedicated rehabilitation center, you're in great shape. But otherwise, in most places, it really is sort of scaled down adult rehabilitative services that don't necessarily meet the physical or psychological needs of children or their families. And I think that's one of the greatest places that we could potentially see increases or decreases in the DALYs, as has been referred to them earlier. I think these opportunities are pervasive, and I think in being involved, if you're not today, if you're just sort of working at your children's hospital, I think you're missing a bigger opportunity and a more impactful opportunity to participate in greater regional trials, to influence your local, state, and national agencies in being sure that they're protecting the interest of the pediatric patient. And I do think things like the Pediatric Trauma Society that's been newly formed, and some of the other regional societies, and participation in even the general trauma societies by pediatric people, is paramount to keep those specific issues in front of the trauma community. We are faced with specific challenges, whereas we know things like screening and brief intervention for risky alcohol behavior is useful and important in the adult population. How do we apply it? Where do we apply it in the pediatric population? And I think these are things that lend themselves to multi-center trials. So I'll skip over that, and I'll go back and tell you my particular piece is that in Arkansas, we don't have a pediatric committee. I don't personally believe that a group of the saved, a group of the dedicated that are already singing off that sheet of music ought to get together and sort of rally around what it is that needs to happen for peds. I think that pediatric people should be integrated into the committees at every level. So in our state's decision-making committees, there are pediatric people on every committee, that as we look at pre-hospital policies and procedures, as we craft state-accepted clinical practice management guidelines, as we look at funding priorities or designation criteria, the pediatric people are there sitting at the table, being sure that the specific needs of the pediatric patient and the pediatric provider are taken into consideration. I think, as Ben pointed out, he mentioned a lot of preventive efforts that need to be in place globally to decrease the burden, and yet even in the states, we don't always face this head on. It's easier for me to sit and just take the patient in and operate on them and take care of them in the ICU and do that. That's more within my comfort zone at times, more within my wheelhouse, but the best bang for the buck is to take on these preventive efforts around the country and to even face some very difficult, politically challenging realities that are burdening the pediatric trauma patient nationally. I think that we also have to be integrated into disaster preparedness, because I do believe that if the pediatric people aren't integrated into this, that the pediatric patient can get lost in this. And I think it's a particular problem because, take my institution as an example. We had a flood yesterday that flooded a lot of our operating room, and if we didn't have a plan in place for how we would move patients out of that facility to be taken care of, the whole state would be in a crisis situation. So I think that there has to be a pediatric disaster preparedness plan. It has to be drilled on, has to be accepted at the state level. So back to us, our mortality, as we might have predicted, and has gone up at the Children's Hospital. we've taken that in exchange for the overall mortality in the state going down. Our volumes have almost doubled in the last 6 years since we've instituted the program. Transfers directly from the field, not stopping at local hospitals without preparedness, have gone up. Scene runs have gone up. The age of trauma patients that comes to the Children's Hospital has gone up. But overall state mortality, preventable mortality has been cut by almost 50%. So while we still have a long way to go, I think that David Notrika and his co-authors were absolutely spot on 4 years ago when they said that there really was something more to it, that there was something about the pediatric center and the people in the pediatric center that had a responsibility outside the walls of that center that made a difference in the care of injured patients throughout their community. So I hope this gives you a little bit of sense of where we're going with all this, and I'll be happy to answer any questions. I sure do appreciate it.
Thanks, Todd. That was great as expected, and as always, gave us a lot to think about and a lot to move forward with. If you could stop sharing your screen, and we'll get back to discussion. So, there's obviously a couple obvious questions. Maybe is we've heard a lot. All three talks about opportunities and gaps for where we have gaps in our systems. We have gaps in pediatric preparedness, and globally, we obviously have some huge gaps. From the American College of Surgeons Committee on Trauma standpoint, how do we address these areas where if we know pediatric trauma centers improve care, but there's not enough of us, as you said, to fix that problem alone? How do we address that as trauma centers or as trauma leaders on this global cast today?
I think quite frankly, we're indebted to you, Rich, for sort of pointing us in the right direction, and we've all alluded to it. We have to push the technology and the expertise as far forward in the field as possible. I think that telemedicine is absolutely the right way to do it. I think we create partnerships with hospitals within our catchment area. I think we offer our services, be it general trauma services from the emergency medicine group or the trauma group, to subspecialty areas like burn and ophthalmologic and other things that are even more difficult to obtain. We put ourselves as far forward as possible with this technology. And I think it's applicable. It's applicable to the edges of the state of Arkansas, and it's probably applicable in sub-Saharan Africa as well. But there are not going to be a lot more of us, and there are not going to be a lot more promulgation of children's trauma centers out there from what we've seen. And so we need to come up with more creative use of technology to get ourselves out there.
Great, thanks. I'm going to ask actually one of our panel members, Steve Fenton. I know you've had a lot of interest in or doing some work with telemedicine in the state of Utah. If you can kind of elaborate a little bit more on what you're doing there to help the trauma system there.
Well, I think both Beth and Todd really elaborated on where we have gone with what we initiated. At first we just wanted to link up with different hospitals in order to try and reduce the rate of what we call preventable transfers, or the kids with head bonks that could probably be observed for 4 to 6 hours elsewhere instead of transferring to us across the state. But what we found is, in order to really improve the system, it has to go well beyond that. Telehealth is a part of it, but the true way to make a change is through this partnership. So linking formally in kind of a hub and spoke model. We really wanted to do it with all hospitals in the state. We just realized that's not tenable. And so we're linking with pediatric resource centers in different regions, collaborating with them in a very open and non-competitive way so that we can share protocols and guidelines and kind of get everyone across the state on the same page. And then through telehealth means allow us to share our subspecialty resources that they don't often have in order for the providers on the front lines of medicine, as I would call it, to have that support that they need, not only for themselves, but also to reassure the parents that their child is being taken care of in the best way possible. I think, and I'm interested to hear what both Beth and Todd have to say about this. I really feel like in order to take it to the next step, though, we really need to start looking at quality improvement at a state level. So, all of these institutions are looking at it themselves. We're obviously doing it ourselves as an ACS verified system, but being able to look at it as a larger region across the state to be able to make real change as far as a system is concerned, or providers or resources, et cetera, I think is where a bigger benefit will come from that. And I'm interested to know what they're doing about that.
So that's a great question, Steve. I'll tell you that in our state, the partnership was with the lead agency, with the Department of Health, in a preventable mortality review, a formal Delphi process in which we brought together a panel and reviewed all the deaths. And there was no doubt that the education and the transport resources and then the tiered levels of care around the state ended up improving our mortality significantly. Like I said, we've cut it almost 50%. Our telemedicine, one key difference, I think, our telemedicine ended up being not used to prevent transports, but to assist and support when transports were inevitable. We get on the phone, we get on the telemedicine and on the phone when a transport is coming, to be sure that the care, we're getting as far forward in that care as possible, that the care being delivered at the outside hospital and in preparation for transport is safe and efficient, and they're ready to come. So we use it just a touch differently.
Beth, did you have any additional comments on that?
Mark?
Yeah, just in the sense of two elements. One, regarding the telehealth, I mentioned our regionalization of care grants. So in New Mexico, they have a virtual pediatric emergency department model. And that's based out of the University of Albuquerque. The emergency department at the Children's Hospital there signs on, and they pull in their rural hospitals and their tribal hospitals out in the Navajo and Zuni communities. And Dr. Robert Sapien there is taking a model of you start rounds together, you end rounds together. And again, to develop that competency and seamlessness so that we really have that partnership and buy into the process. So I put that out as one model to really turn our approach onto just the consultative approach versus developing the trust so that you can decide the best allocation of resources of whether to stabilize the child where they are or move them forward. And I agree completely with the concept of looking at the quality improvement at a regional level. And our grantee in Illinois, outside the Chicago area, has pulled together multiple emergency departments, and they review their QI data together. They come up with a process, and they've developed that culture of sharing that I think has really made a difference and gotten beyond the market competition of who's down the street, and really elevated that concept of pediatric care. So there are some models out there to look to and build upon.